So, hello second year dental students. This is your 12th lecture about occlusion. Now, this lecture we will know the definition of occlusion. What does it mean? It will be an introduction for next courses for you to define what is occlusion, the concepts of occlusion and all the terms that are related to occlusion. What we have occlusion of the primary dentition. We will talk about occlusion of the permanent dentition, and then rapidly about curves of occlusion. What do we mean by antagonists, centric stops, and acentric occlusion? So the definition, if we want to say what is occlusion, the definition is the act of closure or closing. Occlusion, so it's closure of two directions. Okay, so being simple, we will have say that occlusion means the contact relationship of the teeth in function or in parafunction. So we don't hear, if we say this is a definition, we don't only relate to the contacts, okay, at occlusal interference, but also we have all these factors concerned with the development and the stability of the masticatory system and with the use of the teeth in the oral complex, what we said last time about the oral masticatory complex. Okay, so as a definition, we find what have clinical convenience as a modern concept of occlusion, that it includes the idea of all integrated system of the functional units involving the teeth, the joints, the muscles of the head and neck. So it will have all of what we say about the teeth itself, the orthodontics, for example, the stability of a denture, if you want to put, the periodontal tissues around the tooth. Okay, all of these are concepts of occlusion. We extend, saying about occlusion, we extend beyond the concept of only alignment of teeth, okay? It's not only alignment of teeth, it's not only occlusal contacts, it's not only the jaw position, it is all of these together, okay? For example, this is the maxillary and the mandibular. You will be familiar with this diagram in a while. Now, if you want to say about some concepts of occlusion, meaning the ideal or the optimal occlusion in natural dentition, it has some features, okay? But we have different terms that are commonly used in discussions when we say about occlusion. Balanced occlusion. Now, at first, if we want to say what is balanced occlusion is the occlusion in which balanced and equal contacts are maintained throughout the arch during the movement of the mandible. This is called a balanced occlusion. We have also, this is, for example, a balanced occlusion. If I return back now, we can have ideal occlusion, what's called ideal occlusion also. When we say ideal occlusion, for example, let's start from the start. If we have multiple concepts, and I'll put it in the end of the lecture. Ideal conclusion, it is theoretical. We don't have something as called ideal occlusion concept, okay? Because occlusal relationships, functional relationships that include very idealized principle and characteristics is not present. We can have something called normal occlusion. Is called when we have class 1 relationship of maxillary and mandibular first molars. We'll talk about it. We have what we call centric occlusion, okay? Centric occlusion refers to the normal occlusion. We have normal occlusion. You can always have also something called physiological occlusion. These terms that I'm saying have different meanings. Physiological occlusion, for example, when we say about occlusion that deviates in ideal, well-adapted way to the environment, to the aesthetics, to the function and dysfunction. So we say it's a physiological occlusion. Having said that, the concepts of occlusion is ideal or normal or physiological occlusion or functional occlusion. For example, functional occlusion means the arrangement of teeth with high efficacy for movement of the mandible. This is functional occlusion because the mandible is only the jaw that moves. The moving jaw is the mandible. So the functional occlusion defines the arrangement which will provide the high efficacy of movement of the mandible. Okay, let's go back. What is balanced occlusion? It means bilateral contacts in all the functional movements or excursions of the mandible. We have on both bilaterally. It will prevent any tipping of the base of the denture, and we don't have necessarily, it doesn't exist in the natural dentition. Balanced occlusion, we use it mostly in the denture basis. Denture, what means is that when we rehabilitate a new full occlusion of the patient, okay, we don't have natural teeth, we have artificial teeth for a toothless, or we call toothless or edentulous patient without teeth. Now, we can have also balanced occlusion can be either unilateral or bilateral. So the unilateral balanced occlusion, when we say that occludes a relationship on posterior teeth on one side contact. When the jaw moves, we have to one side, these contacts are balanced. But the balanced occlusion that we use it in denture is called bilateral balanced occlusion, in which we have, all posterior teeth on both sides, the working side and the non-working side, they work simultaneously on the side of balance, on the balancing side. Okay. Now, we have also centric occlusion. We have intercuspal position of the teeth. Centric occlusion, what do you mean by centric occlusion? It means that the maximum intercuspation, we have something that's called intercuspation. The relationship between the cusps is in maximum intercuspation, and contact attained between the maxillary and the mandibular posterior teeth is at maximum. This is called a centric occlusion. Okay? Centric occlusion, for example, centric relation occlusion we have also, which means that simultaneous contacts throughout the mandible are in centric relation, which is, we'll know what is centric. Okay, these are all applicable to orthodontics or to complete denture, as we said. Okay, full mouth rehabilitation, when we don't have any teeth and we will, or a few number of teeth, and we will want to have a new relationship of the maxilla and the mandible. We will rehabilitate this. Okay, none of this is applicable to natural dentition. And when you ask me why it's not applicable to natural dentition, I will tell you because each individual has different occlusion that suits it. Okay, if we have 1 extra millimeter or half millimeter that is high, we mean high occlusion, it will affect the patient. If we have half millimeter that is low, we say under occlusion, it will be very annoying to the patient. Occlusion is related to not only teeth, but also the periodontal tissues, and also to the jaws, the maxilla and the mandible and the skeletal relationship. That's why we don't have something as called ideal occlusion. Let's move forward. Now, if we say what is development of occlusion, we can say that firstly we have the phase, it's not written here, but the phase where we don't have any teeth at all until 6 months, from birth to 6 months. Then we have the primary occlusion from 6 months to 6 years. This is called primary occlusion. Then we will have what you learned is the mixed occlusion. Mixed occlusion we have from 6 years to 12 years. Okay, and then we will have permanent occlusion or dentition of, occlusion of the permanent dentition. Now we'll give a quick overview of the primary occlusion so that you will know the characteristics, features of this stage. Now each tooth will occlude with 2 teeth of the opposing jaw, and this is natural, okay, in all types of occlusion, except we have 2 exceptions in the primary dentition. We have the mandibular central incisor. It only occludes with the maxillary alone, okay, and the maxillary second molar, which only occludes with the mandibular second molar, which is called E. Okay, this is E, and this is tooth number A. So let me tell you that these are all the only exceptions, and otherwise each tooth has a occluding with two opposing teeth. Occlusion here is supported by eruption of the first permanent molars, because they are the first teeth that erupt. The first molars, permanent molars, when they will erupt at 6 years, this will guide or support the occlusion of the primary dentition. Okay. Secondly, we have what is called interdental spacing. The interdental spacing in between the teeth, it is very important, because when we have in the permanent dentition, it's considered not normal, the interdental spacing. But however, the presence of the interdental spacing is very important, and it is normal feature in the primary occlusion, because it is required to accommodate the larger permanent teeth at a later stage. You know, the permanent teeth are larger in all dimensions. So we need to have interdental spacing between the primary teeth. Okay, the spaces present between the deciduous teeth is often, we call it physiologic. Physiologic, it means it's normal. We call it developmental spaces, physiologic spaces, because we need to have sufficient space to establish proper alignment in the permanent dentition. Okay. For example, if we have malocclusion here, if we have crowding in the primary dentition or insufficient spaced primary dentition, we will have problems or malocclusion later on in the permanent. Okay. This is what we say here in the primary dentition. It is very permanent dentition is dependent upon the primary occlusion and upon the interdental spacing. Now, so physiological or developmental spacing depends on two things: the generalized spacing between the teeth and the primary spaces that are present for according to the jaw sizes. Okay. Now we have incisor relationship, what we say incisor relationship, and we have what is called molar relationship. We will say about this is okay. We don't have here the incisor. I will tell you about the incisor relationship. Normally we have in deciduous teeth, and it is present later, we have what we call the spacing, real spacing, and the deep bite between the upper and the lower. Now, if I want to say the primary occlusal measure is what is called a terminal plane relationship. What is terminal plane relationship? It is the anterior-posterior molar relationship. The anterior-posterior molar relationship here, it is in the primary or deciduous dentition, it is described as terminal planes. So it's in between the maxillary primary second molar and the mandibular primary second molar. The terminal planes are the distal surfaces of these two second primary molars, upper and lower. It was described by Myers. The scientist is called Meyer, so sometimes we call it Meyer relationship. And we have three possible kinds of primary molar relationship: either straight, either step mesially, either a step distally. So we either have straight, it's called flush. It's called a flush terminal plane or a straight terminal plane. Here we will have the distal surfaces of the maxillary and the mandibular are in the same vertical plane. No significant difference between them. Okay, and the difference in dimensions will make both of them fall in the same vertical place, and it's called flush. This is type number 1, and it's present. Sorry, if we have, let's describe first. This is a flush. Type number 2 is called mesial step. In this terminal plane relationship, we will have the distal surface of the mandibular deciduous molar is more mesial. Here is the mesial, more mesial to the compared to the upper maxillary deciduous second molar. Okay, this is called a mesial step. I said about it because it is mostly common. Then we also have something called distal step. Here we'd have the distal surface of the mandibular is more distal to the distal surface of the maxillary deciduous second molar. And in other words, we have the maxillary second molar is ahead of the mandibular second deciduous molar. Now, this is the three types or the three possibilities. Now, what we have significant in it, the determination of the terminal plane in the primary dentition has great importance because after eruption of the first permanent molar, the sixes, the erupting sixes will guide the distal surfaces of the second primary molars. So they will, as they erupt into occlusion, this will have the terminal plane relationship of the primary largely will determine the type of the molar relationship in the permanent dentition. So mostly for a class 1 relationship, which we call this is the ideal, we call it class 1 relationship. Later you will know what is it. The permanent dentition, it's called Angle's molar relationship. If we have flush relationship in deciduous, we will have mostly either class 1 or 44% class 2 relationship in the permanent. Okay, mesial step, which we talked about here in C, this is a called mesial step, and this will have a mesial step in the primary dentition will cause most probably class 1 relationship in the permanent dentition. If we have, number 3, if we have mostly a distal step in the primary, we will mostly have class 2 Angle's relationship. Now, sometimes we have what we call class 3. Now, I would tell you what is class 3 relationship. It can be present in the mesial step primary relationship. Okay, a very small probability of class 3. I will move here because we have a better diagram. This is a terminal flush or flush terminal plane. This is the mesial step and this is the distal step, and each one, as we said, will later on largely determine the type of molar relationship in the permanent dentition, as the permanent sixes will erupt first. And you can imagine how will it look like. This is a possible effects of the terminal plane relationship on the permanent. This is the primary dentition, and these are the permanent dentition. This is what we have talked about. So normally this will happen in the mixed stage. When we have a mixed stage, the first eruption of the 6 or the permanent molars, then we will have a mixed stage dentition. Here we have early transition, late transition, eruption of the permanent incisors. All of the occlusal relationship will be determined from here if we have an early mesial shift or a late mesial shift. For example, if we have a flush terminal plane, if we have an early or a late distal step. This is not so important. What I need you to know is that it affects, the primary affects the permanent occlusion. Now, what are the factors that affect the terminal plane relationship that let it affect the permanent or Angle's molar relationship? Multiple things. Firstly, the differential growth of the jaw, because as we go on, the jaws are also growing, the maxilla and the mandible. It will affect the rate of the growth, will affect it. Also, the forward growth of the mandible, because the mandible has the condyle, and the condyle still grows until the after 18 years of age. Okay, so we always have forward growth of the mandible. It is different. Thirdly, the sufficient leeway space that we will have to, I will have to describe it here. This tells me that if the differential growth, the individual growth of the jaw is different, we will have different molar relationship in the permanent. If we interfered with the forward growth of the mandible by orthodontic appliance, for example, or if the baby, the child went to correct the primary terminal plane, we can have early correction of the permanent molar relationship. I hope you understand now, just theoretically, the point. This is, again, we have what we call leeway space, and let me describe it. This is a leeway space we have in the maxilla and the mandible combined, where we have the mesiodistal dimension of the primary canine. Here is the canine. Here is the canine. And you know that in molars, in primary dentition, we don't have molars. Okay? Sorry, in primary dentition, we don't have premolars. So we only have canine, first molar, and second molar. So the combined mesiodistal dimension of the primary canine and primary first and primary second molars, if it is larger here than the that space for the permanent canine and permanent, here's the permanent canine, and the permanent first premolar and the permanent second premolar, this is what we call the difference between this and this. We call it leeway space of Nance. You will hear about it, and it's different in the maxilla than in the mandible. Now, measurements of this space, the amount of space that is left, is in the maxilla, it is lower than in the mandible. Okay, so in the maxilla, we sometimes have it between 0.9 to 1.8 millimeters, while in the mandible, we have it bigger. It goes from about 1.7 to 3.4 millimeters. This, how does it affect the leeway space that's present here? It will affect the it has significance on the, if we have very excessive, for example, leeway space, it is very favorable. Okay, it is what we search for, the excessive leeway space. Now, leeway space in the mandibular arch, we know that it is more than in the maxillary arch because the primary mandibular molars are wider than the primary maxillary molars. So we have differential space between the mandible and the maxilla. Such arrangement will give me the class 1 molar relationship that I needed in the early max dentition. Leeway space, when it is deficient, for example, if we don't have enough leeway space, in some individuals, we will have unerupted, for example, premolar, sorry, okay, or unerupted permanent canine in the maxilla, for example, because it is highly unerupted, or the lower 5 in the mandible, okay, because we don't have larger space available for the permanent dentition eruption. I hope this was clear.